So the KeyLift device is really designed for patients with neurogenic claudication, secondary spinal stenosis. Obviously, you have to rule out any kind of vascular type of claudication. So then, you image these patients and you look for mild, moderate, or severe stenosis on the MRI. Obviously, with these devices, you want to pick the most severe level and then do that. Pick that as your first level to insert the KeyLift device. So these patients come in and classically they'll tell you, they have back plus or minus leg pain, and it starts when they stand, is worse when they walk, and is relieved when they're sitting down. Other classic examples are the shopping cart sign. What we see is I always ask them, when you go to the local shopping center and you lean on a shopping cart, can you walk much further? And the reason that happens is because now you're putting the spine in this forward flexion, and that actually gives the spinal cord and the nerves more room to work. So what's the first thing you want to do? Obviously, you want to make sure they have medical clearance. And if they have medical clearance, they're ready to go. We're going to do it at an outpatient surgery center. It's going to be done under, IV sedation, or what we call MAC anesthesia. And it's going to be on a prone position, usually on a Wilson frame. And what does the Wilson frame do? It holds the spine in proper position, and it prevents any kind of lordosis. So you put the top of the Wilson frame, which is like a turtle shell, right at the proposed level where you're going to operate. The next thing that's really important is picking the right level under fluoroscopic guidance. And you have to be able to recognize, an L5 from an L5S1, from an L4-5, from an L3-4. And that's really important. And you have to be comfortable with that. Numbering, the proper numbering, is really important. Once the patient's in proper position, the incision is going to be somewhere from the top of the spinous process to the lower portion of this spinous process. And then that incision will be carried down through the skin, the subcutaneous tissue, and then you will dissect down with a Bovie cautery and a Cobb elevator down to the supraspinous ligament, which is the ligament that just spans between two spinous processes. Once you get to that area, then you do what's called a subperiosteal dissection down the spinous process. We use an instrument called a Cobb elevator. And what that is, it's like a big spoon, and it just scrapes along the spinous process. So you Bovie down, you get to right below the periosteum, and then you scrape down the spinous process, and before you know it, within 30 seconds, you're down at the lamina on both sides. Once that is accomplished, the next thing you need to do is say, how am I going to take down the interspinous ligament? And with the interspinous ligament, that's between the two spinous processes. And what's usually used is a bone rongeur. So you're going to identify it first AP, and then go to the lateral view with your fluoroscopy. And then you'll take down the spinous process down to what's known as the spinal laminar junction, which is right there. Once you get down to the spinal laminar junction on a lateral, then you're going to actually take instruments like a rasp, and you're going to rasp through the spinous process, through the facets, and to the other spinous process to prepare the area for fusion. Because you need to have what we call decorticate, or the cortex of the bone, partially removed, so the bone graft will take to that area and form a proper fusion. Remember, this isn't an interspinous spacer. This is a fusion. Once that's done, you then want to be able to size the device. So the next thing we're going to do is actually measure, and it's anywhere from 10, 12, 14, or 16. So we're going to place the measuring device in there, and you'll see it opening the space as we do it. So that's a 16. Let's say the average is going to be a 14. So we were going to put a 14 in this device. So we've already rasped, we've taken down the interspinous ligament. We're now ready to insert the device. How does that go in? It goes between the spinous process. Sometimes you would tap it down. If not, now you expand the device till you hear an audible click. And there you go. So now it's fully expanded. We now release the device. And then the final tightening will be on the spinous process. So we're going to clamp the wings onto the L5, onto the S1. Now at this point, now the device is in place, and now you can see we have a little window on the side, and we also, since we rasped down to the facets, it's time to do the bone graft because we've already created the arthrodesis for the fusion. Now you put in the bone graft, and that bone graft now has a chance, because you decorticated the bone, to form a solid fusion. Once that is done, you will then take the wound and prepare for closure, make sure there's no bleeding, and then finally you do a 3-layer closure with one for deep fascia, a couple for mid fascia, and then subcutaneous interrupted closure, and then you could use staples for skin. A lot of times we put antibiotic ointment on it, a sterile dressing, and then the patient goes to recovery.